bear with me. So I think we all agree about this, that we touched on it yesterday, today. Ultimately, thankfully, compromise is very rare. We are looking for a needle in a haystack. At the same time, we have a very complex system. I mean, any medical field is complex. The physiology of the human body is complex. Here we have a mother and a baby. We have two patients and a placenta in between. I think we all know that, right? And things are changing very dynamically in labor, which makes it, you know, even crazier. Hence, again, very small forum. I think one problem that, you know, almost 20 years in this field now, I keep on, well, okay, 18, I overdid it, is that always there is a little bit of this. So today, when we talk about risk assessment, and yesterday in the strategies, you know, are we trying to diagnose problems, or are we trying to predict, prevent? Is it risk assessment, which, if you think of risk assessment and prognosis, you accept that it's not always going to be correct. Not to mention that if you're going to intervene and prevent the bad outcome, you're already not going to see the bad outcome at the end. And I thank Amy for showing the slides at the beginning, for example, of her talk now, where she showed, you know, yeah, and we could see it very well in Imane's slides as well, how the pH, when the pH was very low, the agreement was getting higher and the precision was getting higher. When the pH was very high in this end, the precision and agreement was getting higher. But around kind of in the middle, things were least precise. And Amy showed as well some strategies at the beginning, said, yeah, we know when that's very bad, and we know when this is very good. And in that kind of ends, you can sometimes treat CTGs as diagnostic, and that's what clinicians sometimes try to do, especially if they're not very open-minded, or if they're really busy, or if they're Barry Schifrin, who's not here right now, so I can say that, you know, they can look at the CTG and say, that's it, this is it, this is bad, this is when it happens. The reality is, it's more complex than this, and we know that. So we are in a prediction prognosis when we look with cohorts, the way Fit for Labor that Mariana presented is designed. Thousands and tens and thousands, and hopefully in the future millions of births will be behind that, right? So you're talking about data, and it's in the prognosis prediction domain, in my view, although sometimes it's. So when you talk about prediction prognosis in any medical field, when we talk about screening tools, cervical cancer, mammography, you know, breast cancer. Ultimately, a CTG in some ways is a screening test. If you keep on thinking of it as diagnostic and try to use it as diagnostic, you will always be disappointed. And in any screening, you know, normally this is something we know how to do, and we know how to tell patients about. We know how to talk to pregnant women about Down syndrome screening, and you know how you can do a first year, which yes, ultimately, ideally has a high sensitivity, but tends to have false positive rate. And yes, people can be anxious. But we do have ways to talk to them about, okay, this is a first-year screening, the false positive rate is high, we are going to do this test for your prostate cancer risks, and then we want to minimize, obviously, the stress we cause, but at the same time, we want to... So it's not different here, and then you would have a second tier, ideally. So when you think about CTG, when I look at that, I tend to think of CTG output with or without software attached to it, is kind of ideally in the cheap and non-invasive region. Yeah, the false positive rate is high, but hopefully our sensitivity is not great, by the way, but let's say if we can push it higher with better tools. But that's where the doctor is kind of the second tier in my head, at least. The doctor is the one who's supposed to piece all the pieces and not do random cesarean section, obviously. But anyway, so that's in my head, so I'll kill that. But I think the message I really wanted to give you is that if you have a precise technology, if you had a good tool, so I completely agree with Jerry, I've been talking about that for 10 years as well now. If we had a better tool, not a heart rate, some blood pressure, as Austin was saying yesterday, anything else, and some of people on my team know how hard I worked, and we'll keep on working on new technologies. Every time we have this PAM meeting, I keep saying that heart rate is not enough. Rick has been working forever on ECG, at least with good quality, and I know you're collecting data to see whether the ECG can help in some way, because heart rate on its own. Anything beyond that, anything that can tell you circulation, absolutely new tools are super necessary. I'll shut up, I promise. If we had a precise technology diagnostic / almost diagnostic too, you don't need massive data sets, you don't need computer science so much. You put on your gadget, you take your measurement, and you say, okay, that baby's sick. If it's IUGR, if it's preeclampsia, we try to diagnose these things. But if you want to prevent a future bad outcome in labor, you know, a baby that is well at the moment but will run into trouble, you have a bit different setup. And if you have that kind of screening too, and if it's imprecise, that's where the big data value is. That's why we're in this field. And I think clinicians who come with a very clinical hat, because we haven't had big data in our world, not only in maternity, we haven't had big data yet. I think people are not seeing it. And you need to work with, not everybody, but clinicians with clinical hats are not seeing that. And that's what AI will do. And that's what will happen in the future. The imprecise technologies will be attached. They have to be attached with massive data attached to it. You need to have a tool to collect that data, potentially non-invasively initially. You need to, what Nicolo showed so nicely today, you know, they're not showing the outcome necessarily, they're giving some minimal information, but you're collecting that data and you're learning what is, and that will take time, that will take funding, that will take dedicated researchers, data scientists with clinicians hand in hand. Collect big data, which then you use to maximize your sensitivity and control and cap your false positive rate. No one ever says that you put in this software now and you're going to keep whacking these false positive rates. Clinicians are in these situations because no one did that part, because there were no computers, no data scientists, right? So you've been disadvantaged, the clinicians have been disadvantaged, they were tossed these CTG tools and they said, go run with it. And we've seen that with other tools, but particularly. So I'll shut up with this, but that's where I think, and I think clinicians in general, you haven't seen it yet. It hasn't really happened yet properly that I know of, particularly in maternity. When you have this imprecise technology, but with the power, because you have no choice. Of course, if I had a better tool, if I have diagnosis, I'll throw this one away and we'll go home. But at this time, we have no better technology nowhere near. So we are stuck here, but we have computers, data sciences, algorithms, AI is booming. So they'll go hand in hand, and you will have a cap on that false positive, right? I'll shut up. But that I think was missing in this morning as well. For you and yesterday in some of the discussions, I'm sorry I was so tired, about how are you going to make sure you don't do more C-sections. Well, you need to make sure you don't do more C-sections. Obviously, you do the right C-sections. But when you have this with the algorithms, it's tuned for that, it's designed for that, and it tells you, your tool is not going to recommend C-section more than whatever. Your tool, and you know what proportion that is, and your tool should never be recommending C-section anyway. It should be giving better information for your clinician, that second tier, whatever it was, to make that decision. It still should be the clinician who takes responsibility and doesn't start. Otherwise, I remember showing a slide years ago on this forum with that NASA robot delivering baby, and someone told me, you can't do that. And I was like, again, to remind, and the audience was very different then, but it's the same concept. You know, you are not going to have a robot now delivering babies, a bit like Veronica's hand earlier. You're still going to have the doctor, but you're going to make it hopefully easier, and you cap the false positive. Shut up. Thank you for the attention.